Hello, everyone. My name's Ed Catholic. I'm in Lexington, Kentucky. This is another edition of GYN Garage, where we're getting together with my partner.
Frank Lawton from London, United Kingdom.
Okay, very good. Today, we're going to take on a consideration of liquid biopsies that are presented by two papers. The lead paper was done by some people in Great Britain, in the United States, excuse me, and the second paper is being done by some people in Great Britain. This paper appeared in Clinical Cancer Research in the last 3 weeks, and it's a very interesting paper where the individuals have done an awful lot of work. First of all, let me say what their goal is to preoperatively discriminate between benign and malignant pelvic masses. To their credit, they focused on high-grade serous ovarian cancers. They've heavily weighted stage 1 malignancies in their discovery and validation steps, but in their proof steps of what can be done in unknown samples, they're really not weighted that high. They've referenced everything to normal fallopian tubes and normal ovarian tissue. They have said that they've included both symptomatic and asymptomatic women. In other words, those women committing their specimens to the study, though that's not something I could see directly in the paper. And they've made some considerations about the fact that that ovarian cancer is a heterogeneous disease. And their validation appears quite extensive. So if we look at really how they went about doing this, what we'll see is that they've got an arm here, which is their exploratory arm to develop what they're doing. They've done this arm heavily weighted with high-grade serous ovarian cancer, and then they've done an exploratory arm to see how this approach works. Now, they've done sequencing here on to see if there's methylation of the sequences, and basically this is an approach where you use bisulfate to convert so that you end up with unmethylated cytosines converted to uracil, and then eventually upon sequencing they turn up as thymidines. And the methylated cytosines in these sequencing fragments are read as cytosines. So that's the basis for what they're doing. They fished out an awful lot of sequencing fragments, and almost more than 1,500. And they use those then in hybridization plots to look at what really this approach will do, and namely, will it do what they've said it will do? And that's that it will find a malignancy. With that in mind, we have to say that how well could we, in their first step, say the separation occurs at the sequencing step? And if we ask that question, what we do is we get an answer from their paper that basically the high-grade serous ovarian cancers separate as really quite well in this red area from the fallopian tubes that's normal and from normal ovarian tissues. If we overlay the serous ovarian cancers by stage on the right here, basically there is no relationship, though the separation is certainly the same it was in the leftmost plot. There is really no relationship to stage when you go ahead and commit yourself to looking at these two situations. So that separation is quite impressive, to tell you the truth. Now, we also have to say now that those results that I've just discussed are based upon the sequencing step, that first step, where you are generating all these hybridization-specific subsets to probe with. And if we look at how the hybridization step goes, we can still see separation here in the left side of this plot, where the red represents the high-grade serous ovarian cancers. But we can see some of those cancers are interspersed in both the benign ovarian cancer, ovarian structure group, which would be cysts and whatever, as well as the normal ovarian tissue group. And so there's a degree of imperfection that's here. And from this concept of the paper, if we move over on the right side of this graph, what we can see is there's different numbers of things that are being analyzed in the three different groups. And with the normal ovarian tissue group on the right here, having the least amount of points into it, and benign not having as much as the high-grade serous ovarian cancer. And what this means to me is if we had more in the normal ovarian tissue group here on the right side of the right panel, would we have more up here? And would it look as good as it does in this representation? So, I'd raise a question there about how this was put forward. But let's just say that it is what it is. How does it end up? Well, it ends up with a sensitivity of 88% and a specificity of 96%. That sensitivity compares about the same as what people have reported for CA-125 and for ultrasound and for the combination of CA-125 that triggers ultrasound. The positive predictive value in their limited number of specimens is 94%, but they have a negative predictive value of 91%. Both of these numbers, the positive predictive value and the negative predictive value, are encouraging. I think we should say that. Yeah. What do we have to worry about? Well, I think the question we have to ask is this a selective assay for just high-grade serous ovarian cancer or not? And it looks more like not, because if we look at the other types in the ovarian cancer family, the other types of ovarian cancer, we see that if we call this top quadrant the most dependable predictors, are the ones that end up in this category, have been predicted the most. We get other types of situations, the low grades, the clear cells, the endometrioids, that are ending up in the most clearly discriminated by our previous look of cancers. But we also get some of these that are missed in the category that we say we have to pay the least amount of attention to. So in the end, what we have to say is, well, what are the pros and what are the cons? Well, the pros are that it does perform with a high sensitivity and a high specificity, but maybe there are too few pieces of data that were contributed for normal plasma and for non-serous endometrial ovarian cancers, epithelial ovarian cancers. And just as I just said, what's the meaning of the high scores for low-grade serous ovarian cancers and the LMPs and the normal population samples? That's this paper in a nutshell. There's another paper that I want to consider. This one comes from Great Britain, and it's an interesting paper. Basically, it's looking at the same type of search for the difference between malignant and benign situations. And the only difference in it is that it uses sequencing and not the hybridization probes. So the work is represented by some highly respected investigators who do very good work. There's no doubt, about that. So let's just say, what can we say to begin with about this paper? Well, the approach in general is to make a cell-free DNA analysis of blood and assess three genetic regions, which are encoded as ZNF154, C2, CD4D and WNT3, and then to look at methylation. But we have to understand that the source is a group of patients with a pelvic mass. This is a little bit different from the first paper, I discussed. So when we set out to look further on how they did it, the answer is right here, and that's that they are going to sequence these regions which they can identify for methylation or non-methylation, and they're going to make their conclusions based upon the sequencing data. That being said, we have to now look at what they really found. And they found some interesting things and one of the most interesting things I'll say for last is that they were able to perform with a sensitivity of the sequencing approach that was at 80%. And if they included DNA methylation approaches with CA-125, sensitivity rose to 94%, which is a sizable improvement and should be lauded. What's not clear from the paper when I consider it is if the DNA methylation is combined simultaneously with CA-125, because the CA-125 could have been collected at any time, and the DNA methylation could be collected at any other time. So that's sort of whether it's an and or an or for both of these approaches. It's hard for me to say. The specificity is good, 97.6%. It drops off a little bit with when we consider DNA methylation with CA-125 to about 87%, which means that the false positive rate has got bumped up, probably due to the CA-125. They found two interesting things. One is that when they made the collections of plasma, results collected at night tended to be higher. And the other thing that was sort of interesting to me, very interesting, is they could go back for long periods of time, which they said was best kept at up to a year, and they could find indications that there was a positive result from the type of approach that they've taken. The sensitivity in those samples was about 30%, so that drops off a lot. When I look at these things in a sense, asking what does it say about early stage disease? How well does this approach fare for early stage disease? Stage 1 and stage 2 cases only amounted to 4 out of 17. So it's heavily weighted for stage 3 and 4 cases. And as I said earlier, the timing of CA-125, is a consideration. Now, the most interesting thing to finish up with that I found here was that they ended up sharing with us, let's say, a diagram of future directions based upon this work here. So this work basically says, here's the whole population of people in terms of a pie. And what we're going to do is we're going to use a women's cancer risk identification index to define a wedge of the pie. And we're going to use BRCA 1 and 2 positivity to make up another small wedge of the pie. And those are the people they feel should be recommended for both the combination of their methylation assay as well as CA-125. And then those people will go on to PET-CT imaging, and that supposedly their suggestion is to rule out further cancers. But the last step is very curious. The last step is even in the absence of a visible pelvic tumor, we're going to send these people on to surgery. And I'm sort of wondering, Frank, if you were the surgeon, where would you look?
Well, exactly. What do you do? I think that is a big jump, and I think the data and I think both the papers have been, certainly the first paper was very honest in what it's done. I think the second paper was heavily weighted to advanced stage disease. And if you're measuring something that you think comes from a tumor and there's more tumor mass, i.e. greater stage, the chances are there's going to be more of whatever you're measuring in whatever tissue you're measuring, blood, peritoneal fluid, whatever else. So the fact that they've seemed to be able to extrapolate findings now saying, well, if our test shows that there's a chance there's disease here, even though there's nothing else that we can see, you should go in and operate. The question will be, well, what do you want me, what, as a gynecological oncologist, what do you want me to do? Just there's nothing to see. Do you want me to do a full lymphadenectomy because it could be there? Is this a staging procedure? Is it a debulking procedure? Do you want peritoneal biopsies? Do you want me to do paraortics? There's a lot of morbidity associated with taking out lymph nodes in people who may not have any disease whatsoever. And I think that jump from what they're saying, this is the future. It might be the future, but it's not in the future that you and I will be operating in. I think that is not, you cannot produce that. You cannot rely on the data that they've produced to justify that sort of intervention. It's completely inappropriate and actually maybe unethical. Sure.
Well, in the sum and substance of this thing, I think one thing we can look about at the first paper, it really had a specific approach. It was actually going into sequencing things that were specific to high-grade serous ovarian cancers. The second one reached out and said that we're going to pick some regions that we have reports of being gene regions that are associated with high-grade ovarian serous ovarian cancers, and it's not quite as specific. And this is in contrast to the general liquid biopsy approach, which is very quite agnostic. It's looked at something that works on every cancer or a lot of cancers, that type of thing. So, that's the sum and substance of where this area is with regard to liquid biopsy. I will say that for liquid biopsy in terms of ovarian cancer, that second paper by the British group, the last 4 references do shed some light on studies that have been done, as well as a systematic review that's there of liquid biopsies in ovarian cancer for anyone who's looking, to see what else is out there. So, Frank, I think we've covered these 2 papers. I look forward to doing this again.
Yeah.
And otherwise, I'm going to say Merry Christmas to you, because I that's what I say rather than Happy Holidays, but Happy Holidays too. And,
yeah, we do Happy Christmas. Yeah.
So anyway, I'll see you in a month in the new year.
Yes. Happy Christmas. Happy New Year. See you.
Okay. You bye-bye.